So good afternoon, everyone. So I'll be speaking on selection of first-line targeted therapy for BRAF-mutated non-small cell lung cancer, and thanks to Dr. Aparna, she has made my talk much easier, and so I can just rush through my slides. And moreover, we don't have much of updates also on BRAF. So BRAF V600E mutation, it leads to a constitutive activation of MAPK pathway. As we all know, BRAF is a serine thiokinase belonging to the RAS, RAF, MEK, ERK pathway. It is frequently mutated in many cancers. The BRAF mutations is approximately in 1 to 5%, but I'll say 2% of the non-small cell lung cancer cases. BRAF V600E is the most common BRAF mutation identified in non-small cell lung cancer. Could be significantly associated with female gender and older age, but not with the smoking status or the disease stage. So it is a targetable mutation, and targeted therapy has significantly improved the outcomes in patients with BRAF mutated non-small cell lung cancer. This is what the NCCN says. The BRAF V600E mutation discovered prior to the first line of systemic therapy. The preferred is dabrafenib plus trametinib or encorafenib plus binitinib. And if BRAF V600E mutation is discovered during the systemic therapy, complete the planned systemic therapy including the maintenance therapy or interrupt, followed by dabrafenib plus trametinib or encorafenib and binitinib. Just slide on the mechanism of action for dabrafenib and trametinib. It is an inhibitor of some of the mutated forms of BRAF, including the BRAF V600E as well as the wild type BRAF and CRAF kinases. And trametinib, it is a reversal inhibitor of MEK1 and MEK2, preventing their activation and the kinase F activity. So BRAF V600E inhibition with dabrafenib monotherapy leads to paradoxical activation of the downstream effectors, the MEK and ERK, which leads to tumor progression. And the combination of DNT, it allows concomitant inhibition of MAPK pathway and abrogates the paradoxical activation as seen with dabrafenib alone. So most BRAF mutations, they lead to expression of the mutant BRAF protein, and combinations of BRAF and MEK inhibitors, they demonstrated the synergistic anti-tumor activity and could prevent or delay the acquired resistance observed with the BRAF inhibitor monotherapy. So this was the prospective study, the BRF-113928 study design. I hope everyone is aware of this study. So in cohort A, it was monotherapy with dabrafenib. In cohort B, it was the treatment, the patients who had received first-line treatment before, who received dabrafenib and trametinib, and cohort C, which were treatment naive and received dabrafenib and trametinib. So primary endpoints were investigated assessed ORR, and secondary endpoints were DOR, PFS, OS, and safety. The inclusion criteria was stage 4 non-small cell lung cancer, measurable disease, presence of BRAF V600E mutation, and ECOG PS 0 to 2. In the cohort A, it was prior progression after receiving one or more than one platinum-based chemotherapy. In cohort B, prior progression after receiving 1 to 3 lines of systemic chemo or for the advanced non-small cell lung cancer. And in cohort C, there was no prior systemic treatment for the metastatic disease. Exclusion criteria was history of other cancers within the past 3 years, previous treatment with BRAF or MEK inhibitors, symptomatic, non-stable, or more than 1 centimeters of brain mets. So cohort A efficacy results. So median follow for this analysis was 10.7 months. Median age was around 66 years. The median PFS was 5.5 months. Median overall survival was 12.7 months. So dabrafenib was the first drug of its class to demonstrate the clinically meaningful anti-tumor activity with durable objective responses in BRAF V600E mutated non-small cell lung cancer with overall response rate of 33%. And safety profile was manageable and generally consistent with the previous studies. So in the cohort B efficacy analysis, the median follow-up was 16.6 months, median age was 64 years, and with the overall response rate of 68.4% and disease control rate of 80.7%. The duration of response was 9.8 months, median PFS of 10.2 months, and median overall survival of 18.2 months. So DNT demonstrated a robust anti-tumor activity and a manageable safety profile with previously treated metastatic BRAF mutated non-small cell lung cancer with an ORR of 69.4%, median DOR of 9.8, median PFS of 10.2, and median OS of 18.2 months. The cohort C efficacy results. The median follow-up was 16.3 months, median age was 67 years. I cannot go into all the details. The ORR of 69.9%, the median duration of response of 10.2 months, median PFS of 10.8 months, and median overall survival of 17.3 months. So this was the first study that tested the combination of a BRAF and a MEK inhibitor as first-line therapy in patients with BRAF-mutated non-small cell lung cancer. And it demonstrated a substantial anti-tumor activity and durable response and manageable safety profiles in patients with treatment-naive BRAF-mutated non-small cell lung cancer. So the most frequent adverse events, more than grade 3, occurring in more than 5% of patients were hypertension, hyponatremia, neutropenia, dyspnea, and pyrexia, and increased ALT and AST, and anemia. A higher rate of pyrexia was observed with the combination of DNT as compared with the dabrafenib monotherapy. So dabrafenib monotherapy and DNT demonstrated a manageable safety profile in pre-treated and treatment-naive patients with BRAF-mutated non-small cell lung cancer, with the most common adverse events was more than grade 3 pyrexia occurred in more than 6% of the patients. Considering the genomic analysis in association with the BRAF V600E mutation, other additional genomic alterations might potentially sustain the MAPK activation or trigger the additional signaling. Patients whose tumor had concomitant genetic alterations in the PI3K pathway showed a trend towards decreased overall survival. And coexisting genomic alterations, they might influence the clinical outcomes for patients with BRAF V600E mutated non-small cell lung cancer. So the combination of DNT resulted in a higher ORR and a longer PFS when compared with the dabrafenib monotherapy. The ORR and duration of response, PFS and OS observed in the treatment-naive patients was similar to those reported in the previously treated patients receiving the combination treatment. And the safety profile of the combination therapy was manageable and similar to the previous experience in the patients with the BRAF-mutated metastatic. So based on these results, the dabrafenib and trametinib is recommended as a first-line therapy. So, coming down to dabrafenib plus trametinib versus the standard of care as first-line therapy in this real-world practice study design. So, real-world retrospective study compared the effectiveness of DNT versus the standard of care regimens in patients with the BRAF-mutated non-small cell lung cancer. The patients were included from Flatiron Health NSCLC database from Jan 2011 to June 2020. Patients received first-line therapy with DNT or one of the 3 standard of care regimens, either pembrolizumab plus platinum doublet chemotherapy, pembrolizumab alone, or platinum doublet chemotherapy alone. I will not go into the details. So the efficacy outcomes, the median real-world OS DT versus pembro plus PDC was 29.3 versus 17.7 months. The DNT versus pembrolizumab was 29.3 versus 10.9 months, and DNT versus PDC, that is platinum doublet chemotherapy, was 34.7 versus 9.7 months. The real-world PFS, DNT versus pembro plus PDC was 9.6 versus 10.5 months. DNT versus pembro was 10.5 versus 5.9 months, and DNT versus PDC was 13.7 and 4.9 months. You can see here in the graphs also. So the key findings were numerically longer in patients. The overall survival was numerically longer in patients who received DNT versus pembro plus PDC or pembrolizumab alone. Statistically significant longer in patients who received DNT versus PDC. And PFS was similar between patients who received dabrafenib and trametinib versus pembro plus PDC, and numerically longer in patients who received DNT versus pembrolizumab alone, and statistically significantly longer in patients who received DNT versus platinum doublet chemotherapy. So median real-world OS and real-world PFS with first-line dabrafenib and trametinib, pembrolizumab or PDC are similar to those previously reported in patients with metastatic non-small cell lung cancer receiving these agents. The real findings support the use of first-line DNT for patients with BRAF-mutated non-small cell lung cancer. So this drug, since is not available in India now, a phase 2 open-label single-arm study evaluated encorafenib in combination with binitinib in patients with BRAF V600E positive metastatic non-small cell lung cancer in both first-line and subsequent therapy settings. The objective response rate was 75% in the treatment-naive patients and 46% in the previously treated patients. The median PFS was not estimable for the treatment-naive patients and 9.3 months in those who were previously treated. The most common adverse events were nausea, diarrhea, and fatigue. One grade 5 treatment-related AE, that was intracranial hemorrhage, was also reported. So, to conclude, dabrafenib plus trametinib or encorafenib plus binitinib as the preferred first-line therapy option for patients with BRAF V600E mutation positive advanced or metastatic non-small cell lung cancer, dabrafenib plus trametinib or encorafenib plus binitinib as subsequent therapy option if the patient with BRAF V600E mutation did not previously receive a BRAF inhibitor, and single agent therapy with dabrafenib or vemurafenib can be considered for those who do not tolerate dabrafenib or plus trametinib. Thank you so much for the patient listening.